Top Bed Talk.
Thank you, everybody. I'm Jeffrey Gum from Louisville, Kentucky at Norton Leatherman Spine Center. I'm going to be talking about perioperative pain control from a spine surgeon's perspective. We have to do better. Appreciate the opportunity. So the opioid epidemic by the numbers, no matter how you break this down, the statistics are pretty terrible here in the United States. Stats from 17 talk about almost 4,800 or 48,000 people dying just in 2017. 81,000 people used heroin for the first time. Over 2 million people used or misused opioids for the first time. So these statistics, no matter how you dissect them, are pretty terrible and awful to look at. And for the most part, they're continuing to increase, and we're not doing much better with these to date. If you look at regional variation in this, I'm kind of planted right in the heart of this, right? Our center sees opioid-related issues on a daily basis. Kentucky, Ohio, West Virginia kind of being the worst within the country. And if you look at the opioid overdose deaths or opioid overdoses, when you compare these to other causes of death in our area, we're really number two. We're right behind cancer, and this is above accident, diabetes, death by firearm, etc. So we live in an area where it's pretty terrible with regards to opioid-related misuse and overdoses. So it's been such a bad issue in our region that we've made the cover of Time magazine at least 3 or 4 times over the past decade. And all of these have been discussing heroin overdose, heroin use, and misuse of opioids. Our center, right, I started practice and finished my training about 7 years ago. And since then, we've noticed this exponential increase with regards to spine infections. And typically, spine infections or osteomyelitis of the spine are folks that have diabetes or bad comorbidities and typically older. All of a sudden, we started to see much younger patients coming in with these bad spine infections. And by and large, they were all opioid related or from IV drug use. And there was a point in my practice where almost every single weekend or every single day we were on call, we had these infections shipped in that required a surgery, typically an anterior and posterior spine surgery. So we were seeing a huge increase or influx in the numbers of folks that needed surgery for this. Over time, we started to speak to the press about this, and it's not always best to be known for the infection guy in spine surgery. But over the years, I did several press releases with the news to show that our numbers were drastically increasing, and this was an issue that we were concerned about within our community. I ended up in several news channels, which is good to get some press, but not always good when you're always the guy plastered next to spine infections. This is really where my interest in this space took off, right? So first I wanted to look at our osteomyelitis numbers and the ones associated with IV drug use. And what we found that there was an obvious increase from 13 to 16 with regards to non-surgical and surgical spine infections. We found that the surgical infections had gone up 12-fold after about a 4-year span. And I do a lot of economics research in the rest of my spine care. And so what I was really interested in to start to see how much resources these folks were consuming with regards to healthcare dollars. And what we found was when you compare them head to head to other folks with osteomyelitis, it was pretty similar. The amount of dollars or expense these patients were incurring to the hospital when they were in. But it was really rare for folks this young to come in and stay in this hospital this long and consume this many resources. So we did find that there was an increasing medical and economic burden secondary to IV drug use, which is downstream from IV drug use. And so after I started to look at these numbers, it's really when I took a step back and asked myself, how did we get this situation, right? So why is the opioid issue such a big hurdle, especially in our community? And really, I'm of the opinion that this started in 2001 when the FDA and the Joint Commission said that the pain is a fifth vital sign. So all of a sudden, they felt that we were under-treating patients with regards to pain, which related to poor patient satisfaction. And now pain was being recorded just like other vital signs. And we as providers, it was our job or our task to control this pain. Along those same lines, I feel like it was really this window of time where there was a lot of misleading information, right? The FDA had approved labeling for drugs such as OxyContin, which we now understand the effects of medications like that, saying that there was little iatrogenic addiction potential and very rare, right? So it's 20 years ago when the FDA was promoting these types of medications or approving these medications with these labels saying that it is rare to be addicted to these long-term delayed release opioids, which we now know is false information. If you look at opioid prescriptions dispensed, we were also in this time frame without even pain being the fifth vital sign, that this was really just going through the roof. So opioid prescriptions were going through the roof. The Joint Commission, which is our hospital accreditation center, is really telling us that we need to control pain a little bit better over time. When you start to look at some of the systematic or meta-analysis, the reviews of this, what we found that currently the opioid crisis is secondarily in part to opioid use following surgery, right? And so, in my mind, as a spine surgeon that inflicts a pretty big hit on the patient from a pain perspective, and we have to control their pain afterwards, I really wanted to ask myself, are we part of the problem or are we part of the solution, right? And so spine surgery, painful. Patients typically take opioids afterwards. Well, what did that data look like? And in the literature, there was definitely a link between postoperative opioid use and subsequent development of opioid dependency. Here's a study that's specific to lumbar fusion. It's one of the most common procedures we perform at our institution. And the number that would just blew me away was up to 25% of opioid naive patients that don't take opioids on a daily basis, come in to see us for an elective spine surgery, and at 1 year are still taking opioids. That is a terrible statistic, right? That made me feel like we were part of the problem. The other studies showed that it wasn't necessarily the amount of opioids that was being prescribed, it's the duration, right? So in this study showed that each refill or additional week of opioid prescription was associated with a larger likelihood of opioid misuse, and this was predictive of long-term opioid dependency. So I felt like we were not helping the problem, right? At the same time, I'm involved in a couple international study groups. One that's called ISSG, and it was really primarily based here in the U.S. And another one's a European spine study group, and we collaborate to do a lot of deformity and spine work. At the same time, I was discussing with folks from Japan, Europe, Canada, other areas of the world, is this such a big issue? And some of the centers said, yeah, it is. They're seeing this spread out as well. But there are a couple of places, especially in the Asian countries, where they don't prescribe opioids routinely. The patients were not, that is not standard of care, right? So they'll get a very small amount of opioids after a big surgery, same surgery we perform. But the societal perspective is that they don't get these long durations or long timeframes of opioids that continue to be prescribed. And so this is another study that we were interested in looking at. And what we wanted to do is look at adult spinal deformity surgery, kind of the biggest of biggest spine surgeries. And we wanted a propensity matcher, match Europe American patients versus Japanese patients. So we looked at patients that underwent 5-level or larger deformity correction or surgery, and we took a U.S. cohort, a Japan cohort. We tried to match them 1-to-1 based on a bunch of different factors: age, gender, certain perspectives of the procedure. The first thing that we found, if you look at those patient numbers, we went from 619 to 34, 179 to 34 in Japan, that it was very hard to match Japanese and U.S. patients 1-to-1 based on these parameters. So they were pretty different populations to start with. That's why we had such small numbers that we actually got matching parameters on. But when we matched those patients head to head, overall, what we found that 35% of U.S. patients were still taking opioids at 2 years, and 9% of Japanese patients. That's a huge difference, right? So that's a 3.5-fold difference from Japanese patients versus U.S. patients, which tells us that this is not only it's not just a patient problem, it's a perspective, it's a cultural issue too, right? And your environment sets the stage for this being successful or non-successful down the road. So again, this was a time for self-reflection. Are we part of the problem, right? As a spine surgeon society, are we part of the problem as our center? Am I part of the problem individually? Am I giving my patients too many opioids? And I really wanted to dissect this and become part of the solution, which really helped push my work and desire to be involved in the space. And so I started to work along the lines of this called Opioid Minimization Initiation Trial, or OMIT, and this kind of fancy acronym I came up with, where I really wanted to start to dissect areas of my spine surgical care and partner with our anesthesia team to come up with creative ways to really reduce opioid exposure and potentially duration. And the way I initially started to think about it was breaking this up into the pre-op interval, intra-op interval, and post-operative interval. What we found pre-operatively, so education goes a really long way. In our area, there seems to be a pretty low health literacy, right? And some of that is based on our current local environment. But what I really found with patients that were on opioids long term, nobody ever sat down and explained to them the downstream effects to them. Right. So I used to blame this on the patients when I was young in practice. But what I found is education goes a really long way. Number two, we need to set expectations for time frame up front. If you're going to get X surgery, right, I tell folks the average duration or time that you should be on opioids. And, there's a little wiggle room there, but patients need to understand what's appropriate, what's not appropriate. The other thing is utilize pain management physicians to help wean prior to surgery. Patients that come in on very high opioids preoperatively and they're going to undergo an extensive spine surgery, we're not going to be able to control their pain very well afterwards if they have a huge opioid tolerance. So get feedback from the patients, who find the right pain management physicians. If you think about this, it's like sending a patient to a surgeon to not have surgery, right? Our pain management colleagues, right, not always are interested in raising their hand saying, hey, I want to help this patient get off of opioids, which they should, but you need to find the right pain management team to partner with. Another thing preoperatively that we stole from our hip and knee colleagues is really this preoperative oral cocktail. So, Norton or gabapentin, acetaminophen, cyclobenzaprine, all things are easily taken orally before you roll back for surgery. We played around or discussed methadone. Is there benefits to that? What about Celebrex? Well, Celebrex has some literature says it's detrimental to fusions, which is a big part of the type of procedures that we really need help with this. Currently, we do use that. What about delayed release opioids? Should we use a small dose that's delayed? And we've gone away from that. The other thing is, when to start this? What's a pharmacokinetic profile of this? New studies are saying start this earlier, so you get to a steady state before they come in versus right before they roll back for the surgery. So this is some of the work and concepts we thought about preoperatively. Intraop, find a motivated team, right? So the reason I got invited to come discuss this with you guys is the team that I've started to work with is phenomenal. They're very motivated, very interested in a very similar goal, but it's extra work, right? So they have to come in a little bit early. They have to think a little bit more critically about this. And so not everybody's cut out to tackle something like this, but a motivated team that wants to work a little harder with a similar goal, you can accomplish great things. And so it's not the standard of care. It's what some people have told us, which don't follow this algorithm or pathway that we're working on so far. Why does it matter for the surgery, right? That's a small amount of opioid exposure in the grand scheme of what the patient's going to be taking postoperatively. So why does it matter? Why should I work harder on for surgery? And I challenge folks with that because it does matter. Every exposure matters. Intraoperatively, you guys know this better than me, and so I'm not going to spend the time on the exact medications, but we've been working on an algorithm intraoperatively that we continue to work with. This algorithm recently has been accepted to a couple societies for me to present from the spine perspective. What we found is opioid-sparing anesthesia. We used to say free, but what we find is some folks that are taking opioids up front, we still need to incorporate a small amount of them. So I wouldn't say opioid-free. We're striving towards opioid-free, but opioid-sparing anesthesia for lumbar spinal fusion surgery reduces overall consumption, blood loss, operative time. And again, we used a matched analysis technique to compare these two. Less than 5-level lumbar fusion, so not deformity patients now, a little bit smaller surgery. What we did is we took non-OSA patients, OSA patients, we matched them together based on age, gender, smoking, BMI, number of levels fused, and primary versus revision. And what we found in this cohort that we reduced EBL, OR time, PACU pain scores, and total opioid consumption while they were in the hospital. So all of this shows that we're going in the right direction with this now. So we've reduced opioids. We're getting people up quicker. Their pain scores are better. Our OR time EBL is reduced. And so we're very interested in studying this in a more prospective fashion, potentially doing RCT. We've applied for a couple grants recently through our spine foundations and orthopedic foundations. And and hopefully have good results. We did make the cut, the first round of cuts in our spine society looking at this. And so the other thing, intra-op, regional or local adjuncts, I think is a huge help to this. People have started to utilize this a ton in hips and knees and shoulders. That makes sense in extremity surgery, but it's not really taken off in spine surgery yet. So Ben San Pedro, I got to give a little shout out to Chuck Norris's biggest fan, has really been pushing this at our center, has made a ton of progress so far. So I think this is a big future of spine care and really helping minimize opioids during spine surgery. We published our initial cohort of just using tap blocks, right? So that's a regional block that we use for anterior lumbar surgery. And what we found with this was right when we started to incorporate this pre-op cocktail. So pre-op cocktail incorporated with a tap block, that alone reduced our opioid consumption in those patients by 62%. That tells you how bad we were doing prior to this, right? We just started to get in the space and really focus on this, and we made a huge impact in opioid reduction. Same thing, we looked at drivers of in-the-hospital opioid consumption. And the first thing I learned from this is provider variability was all over the board, right? So there was no consistency in how we were prescribing and why we were prescribing and rationales behind that. So we learned a lot from looking at this retrospectively to how to move forward and really reduce this. So postoperatively, like I said, that variation was massive. And some of this was an attempt to reduce phone calls, right? So if I gave patients enough pain medication, it decreased the downstream complaints, phone calls, etc. Right? So what we found now that we've incorporated this enhanced recovery protocol, or at least to an extent, and what we're doing is standardizing the system. There is some protocol component to this. I know some component of your guys' meeting is talking about protocol-driven versus personal perioperative pain control. I think it's a mix of both, right? So you have to have at your institution a baseline protocol-driven approach to everybody. Then everybody has deviations from this, right? So I think it's not one versus the other, right? So not everybody falls in the same cookie cutter recipe, right? But you have to start there to reduce these massive outliers. And for our center, it was the prescriber variation was really big. And so that's what the protocol format did for us. So we started to look at, all right, let's start small. We escalate if we need to. We come up with rationales of why people get certain amount of opioids. So that really helped us move in the right direction. Same with education, right? Besides just educating the patients that I brought up earlier, we need to educate the nurses, the providers, everybody in the system of what the goals of this are, why we're trying to reduce this. Also, IV opioids, especially PCAs, right? So we've omitted a ton of those over the past 5 or 6 years. Nobody gets a PCA nowadays at our center unless it's for tumor surgery for the most part, but definitely not in routine spine surgery. NSAIDs, there's still a big debate on whether those could be incorporated with fusions. It's a little tough with that. The other thing that I want to hit on is THC or CBD, right? So we're currently studying a synthetic THC that's on formulary for nausea, vomiting in cancer patients that we started to look at pain control. Right now, we're at about 48 or 50 patients with a goal of 140. We've also published looking at cannabinoids in orthopedic surgery, and we found that the studies are a little mixed review, right? They're kind of all over the board. But so far, I think we have seen a benefit in our folks, even though it's been a blinded study. It's a double-blinded RCT study. We're about to analyze all the data. But I think there is a role for cannabinoids in this space in the future. Exactly how extensive we lean on this, I'm not sure at the moment, but I think there is a role. And part of me being interested in this is just coming up with creative ideas to really dissect this and make sure we're doing the best as possible and being part of the solution. Next step in our local studies, right? So I really want to look at the deformity or larger surgeries a little bit more because I think the longer the surgery is, right, the less opioids we're doing, the bigger the delta we're going to see. We're going to see a much bigger difference when we start to mobilize those folks. Less medical complications since they're not getting a truck full of opioids while they're asleep. Need to secure funding to try to work on this. Expand our regional experience and offering. Ben San Pedro and the team is really pushing this. And I think this is going to help us turn the corner with it. I think we do need to start to look into THC or CBD dosing studies. And I welcomed anybody locally saying that anybody interested, even if you have no research experience, I want people engaged, interested in this long-term goal of ours. In summary and take home, decide to be part of the solution. You know, if you see a problem consistently at your center, don't just ignore it, right? Be a part of the solution. Be a part of a team, right? Life's easier. It's more enjoyable to come to work and be a part of the team to work on this. Be proactive, right? Educate patients, educate nurses, educate the rest of folks, your perioperative pain folks, to discuss the goals, what we need to do as a team. Standardization goes a long way, but personalization is part of the future. And in addition to this, it augments the standardization. That's the baseline. Learn from other specialties. That's where we stole the THC concept from. Remember, this is a culture and expectation problem. Our patients here in the U.S. demand this, right? And there's other cultures that it's not an issue, right? So there is an expectation issue that I think we need to address to make this more successful in the future. And also, let's change the world. Let's make this better, right? I love spine surgery. I think our patients have great outcomes. I really want to see spine surgery in the future with minimal to no opioids and our patients still being super satisfied with the care we deliver. So I appreciate everybody's time and allowing me to present this virtually and some of the work from a spine surgeon's perspective. Thank you, guys.
Top Bed Talk.
EBPOM USA is coming up July 15th. Check us out at ebpom.org. We're going to have amazing conversations with key opinion leaders from around the U.S. about everything perioperative medicine. Again, check us out at ebpom.org.